Hey folks, if you're just joining us, come on in, settle in, and we're going to get started very shortly. Good afternoon. I'm Professor Larry Jacobs. I direct the Center for the Study of Politics and Governance at the University of Minnesota's Humphrey School of Public Affairs, and we are hosting today's program, and I've put it together. Before we begin, I just want to invite you to participate. You'll see at the bottom of your screen, there's a Q&A button. Please click that, send us questions. We love questions. We're going to get to as many as possible. I want to welcome and thank you for joining us for today's program, Healthcare Innovation and COVID-19. Our guests today are spectacular. I want to begin with Michael Chernew, who's at the Harvard Medical School. Michael is speaking today as a Harvard professor and not as the chair of what is known as the Medicare Payment Advisory Commission. This is an influential body of independent, nonpartisan experts who provide advice to Congress about the administration of Medicare. In addition to wearing that hat, Michael is very well known as a researcher, looking at a whole slew of questions, particularly related to healthcare costs and strategies for controlling them. We're also pleased to have with us Chris Snowbeck, who is the healthcare business reporter at the Star Tribune. Those of us in Minnesota know Chris as really the lead reporter in Minnesota. Those of you joining us nationally, and remember Robert Pear, this is Minnesota's Robert Pear. He also serves on the board of directors for the Minnesota Society of Professional Journalists, which is kind of the Pulitzer of reporting in Minnesota. Great to have you with us. Thank you very much, Chris Snowbeck and Michael Chernew.
It's great to be here.
Michael, I want to start with you. We've had, I think this country's really had an extraordinary a reckoning with disparities, economic disparities, racial disparities, and many folks in the area of health policy have thought long and hard about this. And there's also been this debate and conversation and policy work around something known as social determinants. Could you tell us how you think about health disparities and what is known as the social determinants of health?
Sure. Thanks, Larry. It's great to be here. So health disparities broadly refers to differences in outcomes across classes that we care about. As you mentioned, it could be by income, it could be by race, it could be by ethnicity, it could be by other types of things we care about. Social determinants of health refers to factors that contribute to people's health that aren't the things that we typically consider clinical factors, broadly as the name would suggest, social factors. So that might be housing insecurity, food insecurity, your living situation. So if you live alone, for example, you're limited in how you might respond to certain types of treatment. If you get a hip surgery, it's much harder to manage if you're living alone than if you have someone to help you, for example. So social determinants of health is the broad name for all of these things that affect your health and your health outcomes that relate to the broad context of your living situation and environment.
Thank you. Chris Snowbeck, you've been covering Minnesota now for some time. How would you characterize the status of health disparities?
Yeah, it's a real problem in the state. I mean, I think the state healthcare leaders in the state, I think, rightly, are proud of sort of the state's ranking, if you will, on all sorts of sort of health measures, but they, I think, are getting better about quickly acknowledging that within that there are some real problems with disparities, racial and ethnic. And I mean, I've been for the last 15 months, like most health reporters, I've been doing an awful lot of COVID reporting. And of course, it's often said rightly that COVID, really put a spotlight on these disparities. And I just wanted to mention a couple of things along those lines that are real focused on Minnesota. I mean, I in September, I did a long feature story, terribly sad story about a Latina woman who died. She was pregnant. The baby made it, thank goodness, but just horribly sad. And what was beyond the personal tragedy, just the numbers at the time were that if you looked in Minnesota, there were 900 pregnant women who had been infected with COVID at that time. And 339 of the cases were among Blacks, 239 among Hispanics. In other words, more than half, non-white. Fairview, one of the big hospital systems here. By the way, can everyone hear me? I want to make sure. Okay. But, Fairview is one of our biggest hospital systems here, and they just did a study that came out about a month ago. And, just looking at all COVID patients, not just pregnant women, but again, in Fairview's all Minnesota hospitals, over 50% of those hospitalized non-white populations. This is a pretty white state, candidly, right? So, I mean, the COVID numbers really show the issue in the state. And the other thing I guess I would just mention is that, I apologize if I keep referring to this theme throughout our conversation today, but I mean, the pandemic has kind of eclipsed so many healthcare issues. While shedding a light on disparities, one of the things that got missed is the Minnesota Community Measurement, one of our good, sort of report card agencies here in the state. They've long done studies on optimal care for diabetes and vascular problems and whatnot. And they put out a big report just a few months ago, just putting front and center how that folks in racial and ethnic minority groups are much less likely to get that optimal care. Also highlighting non-English speakers in the state. I mean, there's overlap, but real disparities there. So anyways, I don't know if that answers it, but it's a real problem.
Michael Chernew, there has been many decade concern about the United States healthcare expenditures and health expenditures. And this goes back a number of decades. Over the last 15 years, we've been bumping along just under 18% of gross domestic product, which is the economic activity of the country. You look around the world and most other countries are half that or well less than that. There are lots of ways to measure it, but the conclusion is America is spending way more, has been spending way more. Now we're into a new era in which there is this focus on health disparities and mitigating those. There's also a concern about expanding coverage to more people. What is it going to take for America to control costs in order to do an effective job controlling or mitigating health disparities?
Larry, that's like a 6-seminar kind of question. I hope your listeners aren't expecting the quick, pithy answer, because I'm not going to give them a quick, pithy answer, mostly because I don't know, but I'll watch the chat for answers. I'd like to separate them out from them. We clearly have an expenditure problem, as you pointed out. And as we grapple with that expenditure problem, many of the solutions, one of the more popular ones, for example, is to charge people more out of pocket when they go to the hospital or when they go to the physician. Those types of solutions to spending, the ones that require people to pay more out of pocket, say high deductible plans, have a tendency to potentially exacerbate disparities. And so as we begin to grapple with our spending problem, we need to think through how the savings, or at least the reduced increase in use, might help us solve some of our other problems. But for example, when healthcare premiums rise quickly, it becomes harder to finance care. It becomes more expensive for the government to subsidize the subsidies they have on the exchange, for example. So I think that is all true, but it is not the case that if we take action to control expenditures, we will inherently address problems with disparities. That's a policy choice. Whether we decide to expand Medicaid or not is a little bit of a separate question. How we decide to finance all of our programs to support better access for people in disadvantaged populations, all of those are policy choices. The financial pressure just makes it harder. And the details of those financial pressures differ between the main segments of coverage, Medicaid, commercial, and Medicare. So we face different challenges in different subpopulations, but everybody is struggling with how to pay for the care we need for everybody, but with a particular attention on the groups that we think are most vulnerable.
And just to be clear, there's a distinction here between healthcare spending for the whole country and then the prices that individuals are paying, whether it's for our premiums or the deductibles or other cost sharing that you have to do when you see a provider. Michael Chernew, though, I want to come back to you just a little bit on this because we have made a policy decision to expand coverage to over 20 million people through the Affordable Care Act, which Supreme Court is once again upheld today. So isn't that decision that we're now on the path of expanding Medicaid? We've created a marketplace for individuals to get private insurance with subsidies for most folks and other steps. Doesn't that put us in a more dire situation than we have been in the past?
Well, I think it might put us in a better position. I'm not sure I understand more dire than what, but I was not expecting the Supreme Court to rule otherwise, by the way. So I think we've been on this path since 2010. I think there are some issues. The most notable one that relates to our overall situation and to disparities is what will happen with Medicaid expansion in the states that haven't expanded Medicaid. But whether there's a problem with care in financing writ large, the Affordable Care Act, even when it's working as designed, had to face those pressures. So getting rid of the Affordable Care Act wouldn't have solved our problems. It would have, just brought us back to the problems we had before the Affordable Care Act. You can debate whether you like how the Affordable Care Act addressed those problems, but there really were problems before the Affordable Care Act. It was one manifestation of how to solve those problems. So every part of healthcare, in the environment we've been in the environment we will be in, has to grapple with costs. And it is true, and I think this is probably what you were getting at, the more the government is funding the care, the more that we care in policy places about the spending trajectory. But just to understand, even in the commercial employer market, where the government is not funding a lot of that care, depending on how you think about the tax exclusion, but in any case, the government's not funding a lot of that care directly, we worry a ton about spending increases. We worry a ton about the hollowing out of benefit generosity. And so the pressures due to high costs aren't simply due to the fact that they're being publicly financed. They're actually just they're due to the fact that they're being financed. In fact, more broadly, I would say there's no magic money tree. So one way or another, all of the money we use to pay for care is coming from somebody. It can be coming from taxpayers. It can be coming from employers in terms of their contributions. It can be coming in terms of workers in terms of reduced wages or out-of-pocket contributions to premiums. It can be coming in terms of patients paying out of pocket for care. But one way or another, all the money is going from us collectively coming from us collectively as a group of individuals to the healthcare system providing us the care that we need.
Chris Snowbeck, towards the end of Governor Mark Dayton's administration, he famously referred to the Affordable Care Act as unaffordable. What's the situation in terms of health expenditures and the prices that individuals are facing here in Minnesota, which is compared to other states, generous?
Right. So again, the pandemic eclipses a little. I mean, just I think most every health cost report I've read, nationally has talked about, 2020 being such an outlier in terms of cost trends. And that was true in Minnesota as well. I mean, for me, the best source is the trade group for the nonprofit health plans in the state. And so they calculated a 2% decline in per person medical spending. What that was driven by, of course, was, essentially a shutdown of non-emergency healthcare in the state for a while, a second quarter of 2020 with like really low utilization, and then sort of a comeback in utilization, but in the second half of the year. But it nets out to down a little bit. So one of the things, of course, everybody's watching is like, to what extent does that all just come back in 2021? I was just reading a Milliman report that suggests maybe not all of it does come back, which I think, raises one of the intriguing questions going forward, sort of in the post-pandemic world. Not that the pandemic's over, it's not over, but it's moderated. Is, I mean, to the extent that there's historically been, concerns about, overuse of care, or, care that, we could do without. In the pandemic, did we sort of screen some of that out in a way that the system can continue to screen it out and operate more efficiently going forward? So that's one of the big questions, which I assume we'll get to. But I could rattle on and on. I mean, within the general trends, I mean, it's sort of a different reality for insurers in Minnesota and hospitals in Minnesota, but maybe we'll get there later.
So I want to pick up on that theme with Michael. There was a lot of concern at the beginning of the coronavirus and the pandemic about how the health system would survive, and which parts of it might not survive. The hospitals were kind of heroic, and were seen that way. There was, people serenading hospitals and hospital workers, and there was a lot of concern about that. You've written, though, in an article in the last few months for the Journal of the American Medical Association, flagging the high prices reflect market power, and you single out hospitals as a driver for those high prices. Could you explain what you mean by that?
Sure. First, before I do, I want to call out all the other types of providers as well. So I don't dispute the heroism of the people working in the hospitals, but the SNFs, for example, were ground zero for a lot of the COVID challenges and stuff. And the work that physicians and the nurse practitioners, et cetera, did across the board has been heroic. Not just their dedication, but in many cases, the danger when there wasn't enough PPE and stuff. So that's absolutely true. I think one problem in health policy is it's complex and the solutions are often nuanced. So it is possible to believe that hospitals acted heroically in the face of COVID, and to believe that hospital prices are higher than they need be in some cases. So, for example, there is widespread academic research, I think it's now loosely unassailable, that when providers consolidate, prices go up. So that means when hospitals merge, prices go up. When hospitals buy physicians, prices go up. For that matter, when big physician groups join together and become a bigger physician group, prices go up. So for the most part, you see an increase in price associated with consolidation of the delivery system. And essentially that was behind what I was writing.
Now, it's interesting if you look at the prices, particularly price per patient by Medicare, as compared to the private rates for hospitals. There's a large disparity. The Medicare does a better job at controlling costs relative to what's going on outside of it. Why is that happening?
Yeah, so first of all, I'll emphasize something you said at the beginning. I'm speaking as my role as a professor at the Department of Healthcare Policy, not as my role as MedPAC chair. But the short answer is these issues of consolidation don't affect the Medicare program because Medicare sets the prices administratively. And in the commercial sector, prices are set through the market system. So I'm a reasonably free market economist, but I think it is hard to argue in healthcare that markets are working well. There is a lot of consolidation. There's also consolidation on the insurer side, by the way, but in any case, there's a lot of consolidation. That consolidation leads to higher prices in the commercial market. It is not a driver of higher prices in the Medicare program.
Chris Snowbeck, we've got a medical system in the southeast corner of Minnesota. And if you look at a whole lot of different procedures, including, let's say, hip replacement, much higher down in the southeast corner, obviously I'm referring to Mayo, than here in the Twin Cities. What might explain that?
I think we need an economist to get that. No, it could be market power. It could be, no, I mean, it's one of the enduring issues I've been writing about over the years in Minnesota, and it's not unique to Minnesota. I mean, it's the term I keep using, sorry, readers, is marquee medicine, or there are high profile systems across the country. Yeah, even in, it seems to me like they're just different communities, have different systems that tend to be the place that everybody thinks, you want to have access to. And so then that can carry over into, an ability to negotiate price. I'm told. I should say, no one ever shows me a contract. So I'm still waiting, but
well, let me turn to Michael Chernew, who's done quite a bit of research looking at these variations within and across regions and states. What would be your explanation for why Mayo charges prices that are so much higher here in Minnesota than what you see in the metro?
Yeah, the great joy in talking to you, Larry, is I think you actually know the answer. You're just in a role that makes you ask the question. I'm where Chris was. I think there is certainly some quality component of it potentially, but largely I think they have a lot of market power, and they use that market power in ways to charge somewhat higher prices. There's a question about whether that's worth it, which is a much, much more complicated question to answer. I think, and I won't speak to Mayo, but I think collectively the evidence is pretty clear that when hospitals consolidate, you see higher prices without an improvement in quality. That does not mean that there aren't individual high price hospitals whose quality justifies what they're charging. It simply means, as a matter of generality, consolidation leads to higher price with very little evidence of better quality.
So,
and could I jump in real quick too? Because I feel like, in deference to Mayo, I mean, what part of what they will tell you is, gets at what Michael was just saying. Is that, unit prices may give you one idea, but if you looked at, they're doing great things for patients. And if you looked at total cost of care, they would say, our patients come out really well. And then there are report cards that suggest on total cost of care, Mayo is still expensive. And you go on, and then Mayo will critique the methodology of those report cards. So, it gets very complex quick, which is one reason I should really write about baseball instead of all this, but so it goes.
We've got a lot of great questions, which we're going to get to in a second. Before we do that, Michael Chernew, I want to read back to you a section from an article you had about 6 months ago or so in the New England Journal of Medicine. And this is more optimistic. You said the key success moving forward as we recover from the COVID-19 shock will be to create a more efficient delivery system. We will have to reduce the amount of low-value care delivered and address excessive prices that burden payers and distort incentives. Can you unpack that for us?
Well, first of all, that's an aspirational statement. So you raised early, Larry, appropriately, the struggles we have with expenditures. And that statement is simply saying if we're going to succeed in building a fiscally sustainable healthcare system, we're either going to have to lower prices or quantity. The thing about quantity is you don't want to reduce utilization of high value care. That's the whole point of the healthcare system, is to give people care that they need. So you have to reduce the utilization of low value care. Your listeners may ask, what does he mean by low value care? And so the short answer to that is a lot of care is delivered in this country that does not provide substantial, if any, health benefit. And it took a long time to acknowledge that fact. We've known that in the research community since the variations work done by Jack Wenberg at Dartmouth. But still, I think most people believe in individual cases, the care that they are told to receive is up the appropriate care. And I would say most of the time it is, just to be super clear. And if anyone's listening, don't listen to your economist, listen to your doctor when you're making clinical decisions. But from a broad assessment of averages, there is care delivered that is not necessary. So this has become much more prominent in the medical community now. The American Board of Internal Medicine Foundation sponsored an initiative called Choosing Wisely that identifies what that care is. A bunch of folks have worked on trying to measure that. Actually, the state of Minnesota may be working with a company, Milliman, to try and measure that. And so that's what we have to do on low value care. We got to get rid of that care.
Michael, can you give us an example, something people might know of as an example of this low value care?
Yeah, so the easiest one, of course, is when you're using expensive branded drugs when a cheaper generic drug would be fine. There's examples of other services like getting certain types of operative testing before low risk operations. A lot of that there's initiatives now people call Stop the Pre-op, because there's a belief that there's a lot of tests that go on before a surgery that really aren't needed. And in fact, sometimes identify meaningless things that cause a whole slew of other problems called care cascades. Vitamin D testing is commonly considered one. A lot of imaging for low risk head pain, certain types of surgical procedures. The Choosing Wisely campaign asked over 70 specialist societies to come up with those types of things in their specialty. And now there's over 400 recommendations. Many of them are nuanced. They don't say don't get MRIs. They say don't get MRIs right away. They don't say don't get back surgery. They say don't get back surgery unless you've gone through physical therapy first. So it's complex, but that's the type of thing people are talking about.
So underlying this conversation about low value care is the proposition that the healthcare system, the providers, the doctors, and others are alert to financial incentives. And when they see a way to get paid, they're attracted to it, particularly if it's a high a payment with low costs for them. And for decades, health economists like Michael Chernew and many others have been studying the effects of these financial incentives. So you could think of this as like chapter 48 in a long running study. Chris Snowbeck, you've written and I know thought about the effects of the coronavirus on telehealth, on other ways in which we've adapted. Do you feel like that's a pretty clear outcome in terms of what's valuable as a result of that innovations or accelerated trends that we've seen in healthcare delivery?
Just to make sure I'm following, are you asking if has the pandemic shown the value of telehealth? Is that
or other sorts of procedures and care?
Yeah, I mean, I don't know. It seemed I think a lot of people were forced into telehealth by the pandemic and found they kind of liked it. So I mean, I think that's a way forward for a lot of things. I think there'll be a. Oh, sorry. Go ahead.
Let me ask this: do you think the benefits of telehealth are so powerful and so well known at this point that we should be looking to transform the healthcare system based on it? Do we know that?
I don't think we know that.
Yeah. So that's part of it. Michael, have you seen aspects of healthcare delivery during the COVID period, and now that we're appear to be emerging from it, that you would say, careful here, this could be one of those emerging low value care situations?
Well, again, I'm going to give you a complex answer. The one thing that the pandemic illustrated, perhaps more than all else, was the value of telehealth. And I think it's universally recognized that without telehealth, we would have had substantially bigger problems than we otherwise would have had. So I put telehealth in my high value care category. That being said, not all telehealth is high value. And so therein lies the challenge. I don't think the COVID experience has led to an across the board acknowledgement yet that we should never do X, Y, or Z, although I think some health services research going forward may identify those things. Once the data comes in, we have time for follow-up. I think there's some real study opportunities there that we will begin to see. But I think the bigger issue about COVID is it's changed aspects of care delivery, particularly around virtual health, in ways that undoubtedly was high value in general, but may have included many low value instances.
Okay, and so I think what I take away from what you've just said is more to come. We need to study this. If we're looking at payment mechanisms, such as paying providers who use telehealth versus in-person visits with a provider, setting that up at parity, that they're paid equally, that shouldn't be done in a permanent way. We need to be cautious here. We need to study. We need to understand the relative values. Is that fair?
Yeah, I think that's true. And I think there's a range of other things about understanding where telehealth works. It's not just what we're paying for it, although, again, to be super clear, price is an unbelievably important part of the system, but it's also how much telehealth we're getting. Are we getting, people can go to get care in situations where they otherwise wouldn't need care because it's much more convenient. I think this is the challenge that telehealth is going to pose, is it's really hard to operate a telehealth payment model in a fee-for-service world because you have audio only, which, by the way, is incredibly important for disparities. You have remote patient monitoring, which is very complicated to figure out how to pay with. You have quick phone calls, you have email connections. So I think that telehealth is going to really challenge a lot of the other aspects of payment.
Chris Snowbeck, you wrote a very interesting article back in May about a collaboration between the Mayo Clinic and Kaiser Permanente of using medically home monitoring and care. And that seems to be tapping into our new kind of tolerance of technology and also the capability. Could you talk a little bit about these medical homes?
Sure. So I think the basic idea that they're using there, and I think it's similar to what others are doing, is they're sort of identifying a subset of things that traditionally have been done in hospitals, and they're going to try and do it in your home. And so they'll outfit your home with a super nice communication thing so that you can be monitored your condition. You have ready access 24/7 to like a command center nearby that can get you help quick if you need it. And there's, it's either EMTs or nurses or, there are folks who are not dispatched in EMT, not in an emergency sense, except that's what they otherwise do, but you get regular access to providers in your home. So there's a component of, technology and also touch, I guess. And so it's a really interesting experiment. It's, Mayo Mayo's a big name, Kaiser's a big name. They're putting some money into it, which is always of interest. It's all kind of got a lot of momentum because CMS, said we'll start paying for it in the pandemic context. So one of the big questions with all this stuff is, how does the emergency liberalization, if you will, of payment, does that continue and in what form? But it's it's super interesting technology, and of course it's always interesting with Mayo. I mean, Mayo is Mayo has huge hospitals, right? And so on some level you would wonder, well, wait a minute, why would they want to take patients out of their beds? But Mayo's also lots of things and has lots of resources. So it's intriguing.
I've been incorporating questions from our friends in the audience here. And Michael, I've got two questions I think you'll consider softballs, and then one that maybe will challenge a little bit. Here's the first question. What do studies show about health disparities between rural and urban areas?
Yeah, so in the pure disparity sense, there's a lot of health challenges that are in rural areas that the health outcomes are often worse than in urban areas. It's harder to get access to the same care in rural areas. There's some other social determinants of health that are going on in many rural areas. Of course, there's parts of urban areas that have similar problems. So there's heterogeneity within both urban and rural. But for the most part, I think rural America faces unique challenges with regards to healthcare, and you see some of that in the health statistics.
A follow-up question or related question, which is related to high fever for a child in a rural area. Telehealth was the perfect solution. The questioner says, for this sort of thing, does that strike you as it's kind of reasonable? I don't know if you call it high quality care.
Yeah, again, I'm an economist, I'm not a physician, but I'm going to go with yes. The point is not that telehealth can't be invaluable. It obviously can be invaluable. The question is that doesn't mean it's always invaluable. Therein lies the problem. There's situations that are much less dire where maybe the right thing to do is just wait a few hours or do some other thing, or you might not need that many follow-ups. You could get through after your procedure, after your visit with fewer follow-ups. But telehealth makes that all easier, which means more is done, which means more potentially, depending on payment, this is the key point, could be billed. So there's certain clinical conditions. Mental health, by the way, is considered amongst the most valuable uses, but that doesn't mean all telemental health is high value. And that's the problem with these things. The service is not good or bad. And that's true for all services in almost all cases. It's when and how the service is applied. And that makes managing it challenging, and that makes it difficult to work in our fee-for-service system.
Okay, here's the third question. How can we explain the Federal Drug Administration's recent decisions to approve the new Alzheimer's drug? No proven benefit, and the cost is about almost $60,000 a year.
Is that a question for Chris? My answer is, look, I don't want to go into the nuances of the decision. It's clear if you look at the advisory panel that the FDA advisory panel was not particularly in favor of approval of this drug. And I think that's perhaps the most important thing to get into the conversation. Why you should explain it, I wasn't in the room where it happened, but I think the overarching motivation, in my opinion, was probably the disease was so bad that people just wanted something. And so it was very hard to take something, even despite very weak evidence. And I might add evidence of potentially serious side effects. It's not simply the evidence of benefit was weak. There's actually potential for real harm. But I think the main thing was, given the severity of the disease, and I can tell you from personal experience, this is an unbelievably devastating disease, that there was just real pressure to get something approved. And I think the fiscal consequences will be potentially dire, depending on what happens through the rest of the process. And it really illustrates the difficulty in health policy when it becomes concrete relative to health policy in the abstract. It's easy to say things when you're talking generally, but when you talk about a specific condition and someone wants access to this drug for their relative for whatever reason, it is really hard to be at the front line of saying, I don't know if this is appropriate.
Okay, so let me just be a little more blunt. Do you think politics and the power of consumers who are desperate for treatment overrode the science, which was quite mixed?
Larry, you're the political scientist. I'm going to be a little more circumspect in my answer. I think it's a question of, look, so I will say as an economist humbly that economics is only one factor that drives decision. Politics is important, and certainly politics played a role in aspects of this. The question is, that doesn't inherently mean it was wrong. I'm not in favor of the decision, by the way, to approve it. But that being said, that doesn't mean it was wrong. I think it's really a question of what traits were being valued and how highly. And so obviously the advisory panel had a very particular view of the benefit, one that I would probably concur with, but not because I have any different information. I just trust the advisory panel, and other people disagree with. And so I think we have to, I don't know exactly how to say much more than that, except clearly the decision makers had a different weight on the evidence than the advisory committee did.
Okay, thank you. Chris Snowbeck, we haven't talked about profitability, and many of the actors in this conversation, the insurers, the providers, are looking at returns, or at least, and some of them are looking at high level profits. And by the way, there are also private investors who are now looking at healthcare as a massive moneymaker. I noticed in the second quarter of 2020 that the Minnesota-based United Health had a $6 billion profit. What does that suggest to you about the nature of insurers and providers? Is there something more general that we can read into that?
Well, I mean, I think that's primarily just right, the dynamic of that many insurers saw, that they set no one had a pandemic related slowdown in utilization baked into their numbers, and so you set premiums of a certain level, sort of more according to historical norms of inflation, and then whoop, there was a big drop in use in that second quarter. I think that's primarily what that's about. And I mean, I'll say, as I said earlier, some of that came back in the second half of the year, not all of it. But the other thing that should be said is, I mean, the insurers, United was upfront in saying, I remember that quarterly call, even, in stressing that, all the ways they were trying to extend discounts or rebates or payment plans or what have you to their customers, which, we didn't know at the beginning of this whether there would be a big drain on employer-sponsored coverage as a consequence of the economic, paralysis with the pandemic. And I think it was a reasonable question at the time, whether, I guess if I'm running a health insurer, and I'm not, but I mean, employer groups are a really important piece of business, and I want to make sure they stay in the game, I guess, if I'm that entity. So I think there was a good bit of, I don't know if give backs are quite the word, but I mean, I don't know. It's a interesting picture.
Michael, I want to ask you about a story that's gotten a lot of attention in Minnesota, I think nationally, and Chris has actually written about it, which was a decision of United Health to initially stop paying for non-emergency care in emergency rooms. And then there was a backlash and quite a bit of negative attention. And now United Health has pulled back and said they're going to delay it and study it more. But I want to just kind of dig in on that, because it seems to me that when you look at the numbers and the kind of situations that United Health was responding to, that they were trying to target this low value care that's expensive. treatments that are, very expensive in an emergency room that can readily be taken care of in a doctor's office. Do you agree with that?
I'm not sure completely what the that is in that sentence, but I think your assessment of the situation is right. The challenge is that it's difficult ex ante to know what the situation was ex post. So
Well,
you're
let me give you some concretes,
Yeah.
because United Health Group actually did a study of this, and they found identified 18 million emergency department visits for things like bronchitis, cough, lower back pain, respiratory illnesses that could well have been treated in a doctor's office. Now, isn't that the kind of thing, if you're a proponent of weeding out low value care, that maybe United Health got this right?
Yeah, well, I don't know. I mean, I think certainly United Health does a lot to try and weed out low value care. I'm not sure I would have started there, but I'm not going to speak for or against United because I don't know the details of that situation. I think the challenge is you could have symptoms that seem like your physician could deal with it, but they actually seem like you could be having a heart attack. So you go to the emergency room because you're not sure what's going on. And then it turns out to be something that when you ask the question, seems like it really should have been treated somewhere else. But you might not have known that's what it was when it actually happened. And the medical community is obliged to treat you once you get into the emergency room. So this is really about where the patients are going, given the systems they're facing, much more. I mean, there are situations where certainly within an emergency room, people can be overtreated. And if you followed any of the surprise billing discussion and rules, there's certainly a lot of things going on in emergency rooms that would make you upset in terms of the prices being charged and a bunch of other things. All of that being said, we need emergency rooms. People need to be able to go to emergency rooms when they think they have an emergency, and providers need to be treated for the patients that show up in their emergency room, right? That remains to be true. It is true that ex post, some of those people might not have needed to belong to the emergency room. And it is probably a reasonable thing to try and set up systems to divert people with minor problems or problems that might likely be minor to some other setting that then they could be sent to the emergency room if they needed to be. Urgent care, telehealth, we've been talking about. There's a range of things you might do. The question in some sense to me is not whether that is the place I would have started for low value care. The question is really how do our payment models make this type of action really difficult? And I think with a broader, different payment model, you might avoid some of these, I think, really unfortunate types of situations. You certainly need to educate patients. You need to give them alternatives when they think they have issues. I think where you get this pushback is when providers given care that may have been reasonable ex ante or done things that were reasonable ex ante to say ex post, oh, this isn't what should have happened. And that's where I think the pushback was. I don't know the details here. And obviously United started in a direction, got a lot of pushback, and now, as you said, they've pulled back some. So again, I speak in generalities when I talked about low value care. You pushed me to give some specifics, which I did. None of those were emergency room oriented ones. And so it's just a question of the choices you make.
Chris Snowbeck, do you generally agree with that?
Oh, I suppose. I mean, it's a. I mean, to me, it goes back to what we're talking about earlier. I mean, and what's really interesting to me about the second quarter of 2020 is that so much healthcare that usually happens didn't happen, and it creates this opportunity, I think, then to study. Well, what didn't happen that should have, what didn't happen that we're okay with, not having had happen. And I guess the one thing that struck me about United's, the proposal is, I mean, we're as I said earlier, we are still in the pandemic, and it's not clear that I think there's a lot we still don't know yet about what the pandemic really did to demand in a way that's troubling. And so it may just have been too soon to put that out there. I don't know. I honestly, to readers out there and viewers, I really don't have opinions on it, but it does strike me as a really interesting subject that to be watching here.
Thank you very much.
Larry, Larry, I just want to jump in and add one thing. Just so there's sort of two issues. One is, how do we think about the money that was not spent in COVID, even though the premiums were paid? That's sort of one issue. Then there's this issue specifically about how do we get rid of low value care and what United was doing. So first, in full disclosure, I work with United and a range of these types of topics, including some incidentally related to COVID, and very much in the spirit of what Chris is talking about. And it just takes a while to get the data to say what we can learn. But you know, United has, I think, a pretty advanced program on social determinants of health. They have an analytics team that spends a lot of time trying to figure out where care can be delivered efficiently. There will always be debates about whether they exercise those tools in the way that they should or the way that people like. And because it's so complicated and nuanced, there's always going to be tension around when are you stepping too far, when are you not stepping far enough. But given the problems we face with expenditures, you're going to get this type of managerial activity, and sometimes I think it will work well, and sometimes it won't. But again, this is not really a webinar about United, but if you look across the board at what they're doing, I think you'll see an enormous number of initiatives, broadly speaking, motivated by an attempt to try and improve the efficiency of care delivery. And the execution of that is a challenge that, of course, every insurer is facing, and for that matter, every provider is chasing. Is trying to figure out how to become more efficient in what they do. It's just challenging.
We're running out of time, so I want to click through some more of the questions that we've gotten. Michael, one of the questions we've gotten is about rehospitalization and the expense of it. And as you know, wearing your Medicare hat, Medicare has set up payment systems that are tied to evaluations of the quality of the care given by hospitals. They go by all sorts of acronyms and kind of tricky names like hospital value-based purchasing, and on this one, hospital readmission reduction program, and there's still more. Do you think these programs work? There's been a lot of attention to them.
Yeah, so first of all, I do think readmissions is an issue. I'm not a huge believer in dramatic success of these types of programs for a whole bunch of technical reasons that we won't go into. But again, I think the challenge we face broadly is in a fee-for-service world, we have a hard time to managing all of these underlying things that go on. And so we can put in place these programs like the readmissions reduction program, for example, which at first we thought worked great. Then the literature came out that said, well, maybe the research that said it worked great didn't fully adjust for some coding issues, for example. And it's become quite controversial. We have to find ways to measure quality. We continue to find ways to measure quality. Readmissions is one measure, but again, I'm not a huge fan of readmissions being a great measure of quality. I like things like patient experiences and other types of outcome measures.
So let me ask you about something you have looked into, which is in terms of cost control, setting the commercial prices at the Medicare rates. Now, Medicare has several different programs for hospitals and physicians that have attempted to set the rates. It's known, if you want to get deep into it, prospective payment systems. And so the Medicare rates are lower than they are in the private arena. And Michael's done some research with colleagues looking at the idea of setting the commercial rates at what Medicare is paying. Are you enthusiastic about that approach?
I'm not enthusiastic about that approach. Just to be super clear for your listeners, just because you do research on something doesn't mean you're enthusiastic about it.
I'm quite aware of that.
Yeah, the reason why I'm not enthusiastic about it, realizing we're in the last 5 minutes and I don't have time to read through the inevitable hate chat I'm about to get, is the fiscal implications of doing that on providers, I think, would be really substantial. You could have providers losing 30-40% of revenue, and to the extent that we're worried about disparities and quality and stuff, I think that's really, really a substantial immediate hit if you're going to set all commercial prices at Medicare rates. That being said, I am in favor of regulating prices at the upper end and the rate of spending growth. So I believe, in the commercial sector in particular, the core problem is prices. We've talked a lot about low value care, but in the commercial sector anyway, we could talk about Medicare, but in the commercial sector anyway, the core problem is prices. And I do believe we need more government involvement to address high prices. It's just, I don't think that solution would be set all prices at the Medicare rate. I think that solution would begin to move down from the top and then continue to monitor what's happening to quality and access, and you can decide how that plays out.
I can almost feel folks in the audience who are advocates of Medicare for all or some variant nodding their head. Is that what you're heading towards? You think government ought to be setting rates?
Well, no, I don't think government ought to be setting rates. I think government ought to be capping rates. There's a big difference, right? And again, we could have a whole webinar on government price setting, the pros and the cons. I will tell you, I speak as my role as a Harvard professor, but I have more experience than many in government processes for setting rates. And I don't want to go through the details, but the short version is, if you think the government would do a good job, sure. If you think the government wouldn't do a good job, it could be a disaster. And so a lot of your views about government rate setting have to do with how well you think the market's working. That's inevitably imperfect. And how well you think government will work. That will inevitably be imperfect. And so usually what happens is the people that want the government to set rates assume the government will do it well and the market stinks. And by the way, the market does kind of stink. And people that want the market to do it think the government is inevitably going to do a bad job. And they talk about super high priced, toilet seats on planes and stuff, and the market will do much better. And by the way, the government can stink at how it sets prices and what it does. And so you're not comparing a perfect market to a perfect government system. You're comparing an imperfect market to an imperfect government system. And your choice there is much more complex.
Thank you very much. Chris Snowbeck, I want to give you an opportunity to have the last word.
Let's talk baseball. No,
Yeah.
the last third there was complex, and as an aside, not that anyone cares, but I mean, as I'm sort of just professionally moving back towards these topics from the pandemic, I mean, it just strikes me two things. One is it's still complicated and difficult. The other thing I just wonder about is, I mean, one thing that happened during the pandemic here in Minnesota is, I mean, Minnesota had a really visionary, innovative employer group in the 1990s that really tried to drive some big change. That group went away during the pandemic. And over the years, I've followed different, sort of employer-led efforts. Employers, I think, have, they've been a font of really interesting ideas of trying to change things. And I'm not sure to what extent they're out there right now. That's one of the things I want to try to look at going forward.
Great, thank you so much. Chris Snowbeck, Michael Chernew, thank you for joining us as well. It's been a terrific conversation. And I want to thank both of you for making it so important. Thank you. I want to take a moment to thank Blue Cross Blue Shield of Minnesota and introduce my good friend Scott Kiefer, who is Vice President of Public Affairs for Blue Cross. Blue Cross has been sponsoring these forums we've had for a number of years, and Scott has been the perfect partner. And I'd like to turn it over to Scott for some closing words.
Thank you, Larry, and my thanks to Chris and Professor Chernew as well for being here today. We've had just a rich discussion. I hope Michael, we can have you back and continue this conversation, maybe revisit the steps that we've taken coming out of COVID. And it's pretty clear to me that there are some obvious takeaways. I would say number one is we have to do our best to remove barriers. So from an insurance perspective, we've learned quite a bit about waiving cost sharing expenditures for first COVID testing. That was ultimately mandated. We also waived cost sharing expense for COVID treatment. That wasn't mandated. And my organization has extended that through the end of this year. So we want to eliminate those barriers, and cost, as Michael said, clearly is a barrier from time to time. We've also learned that telehealth had clear benefits. As an organization, we're looking at telehealth services that may normalize. People have talked a lot about behavioral health. It seems to me that there's a clear benefit there when there's an existing relationship, and because of people's conditions, they may not always want to go in to visit their therapist in person. And as Michael said, we look at an issue like the issue of phone only, something that was clearly not contemplated before the pandemic, is considered very important from an inequities perspective. But also, I know that federal agencies and state agencies have concerns around fraud. So how do we address those? And then related to that, there's the issue that at Blue Cross Blue Shield, we're now talking about the issue of internet access, and broadband is the newest social determinant of health. So how are we going to improve that access, which is important for a geographically dispersed state like Minnesota, and especially at gaps in rural communities where we don't have that access. But it's also an issue for many of our urban communities here in the Twin Cities Metro. And those of us who are working from home have encountered that when we've dropped from those Zoom calls. We think about inequities. We have to address this issue in real time. Looking at the vaccine issues related to inequitable distribution, that is an urgent public health issue that many in Minnesota and throughout the country are engaged in. We have to think about the issues of screening. I know that our clinicians, our chief medical officer worries very much about the impact on decline in cancer screenings through the pandemic, the decline in childhood immunizations, all the things that we want people to go to the doctor for. How do we deal with that? There are a few open questions that we didn't learn, and it's always good to have an economist remind us that there's no magic money tree. Thank you, Michael, for that. And when we think about the outrageous cost of entry of Biogen's new drug for Alzheimer's, Aduhelm, I won't speak to the clinical benefits there. I'm a lawyer, not a clinician, but as a policy analyst, I do look at the price. And I know that from an insurance perspective, there's not an efficient way for us to price in a drug that costs $56,000 a year, particularly when we look at an organization like ICER, the Institute for Clinical Effectiveness Research, said that the value of that drug, the relative value of it was about $8,000 a year. So when we think about low value care, how do we get 8 times the entry price? So many of these issues require more analysis. Michael, I know that you're not speaking for MedPAC, but I think MedPAC has said when we look at something like telehealth, telemedicine, we need to understand the utilization of that along with the outcomes and how do we improve those outcomes. And I'll close by saying a few positive things. On this day, I would be remiss, Larry, if I didn't comment about the Affordable Care Act. I hope that we finally put the Affordable Care Act to rest after more than 10 years. The Affordable Care Act was written with the promise of first, tackling access to coverage. We've seen improvements there. Thank you, Chris, for mentioning Minnesota, the improvements that we've seen in coverage. Actually, coverage increased surprisingly during the pandemic. The Minnesota Department of Health recently told us that. But the Affordable Care Act was written first to deal with coverage and then to deal with the cost of care. So I say it's high time to roll up our sleeves. It's pretty clear that stakeholders, including insurers, aren't going to get their first choice, but we need to have a community-wide discussion and look at the successes of efforts that were cited here, like choosing wisely, and how we can have collaboratives that bring about durable and lasting policy solutions to these issues. So thank you to everyone for tuning in today, and look forward to future conversations. And thank you, Larry, for the partnership.
Thank you, Scott.